Welcome everyone to our monthly series of heart-to-heart webinar. I am Diurese. I am really privileged to be with my co-host, Dr. Kenton Zir. He's a cardiovascular service slide director at Detroit Medical Center. These webinars come to you from Detroit Medical Center. It's a monthly webinar every fourth Thursday. It's one CME accredited activity. The goal of this webinars is for education on topics we started related to the cardiovascular diseases as well as management. But lately we have been going into expanding the spectrum to involve other services related to cardiovascular outcome as well as complications. Again, this is our CME activity. Once you are done with the webinar, you're going to receive an email with a survey. Please be honest and be sincere and candid with us in terms of giving us your honest opinion and also suggestion for future topics. These webinars will be hosted also on our YouTube channel, so you can use this in the reference in the future to share it with your colleagues, your coworkers, or people who are working with and interested in the same topic. With that, again, we're coming to you from DMC, and we'll start with the intro video and then go from there.
It weighs less than 1% of our body mass and is an engine that never stops, pumping almost 2,000 gallons of blood along 60,000 miles of blood vessels every day. Our hearts perform like nothing under the sun. So when your heart needs care, you want a team of experts, board-certified heart and vascular surgeons with over 40 years of combined surgical experience, trained at some of the nation's top institutions like Johns Hopkins University and Mayo Clinic. True specialists in the fields of non-invasive cardiology, interventional cardiology, cardiac electrophysiology, cardiothoracic surgery, and vascular surgery. For over 3 decades, our specialists have been available in Commerce and Detroit because we believe heart care isn't something you wait for.
I need to start the lecture. I need to start the lecture.
Hearts of Metro Detroit.
Again, thank you so much for joining us. Today, we're privileged to have Dr. Professor Imran. He is coming to us from Wayne Health and Wayne State University to talk about a very important topic related to cardiovascular syndrome, diurese or not to diurese, and also cardiovascular outcome and complications in patients with cardiorenal syndrome. Just a brief bio about Dr. Imran. He's Associate Professor of Internal Medicine and Nephrology at Wayne State University School of Medicine. He received his medical education at Jordan University Science and Technology and finished his internal medicine residency at Seton Hall University in New Jersey. He received his training at Baylor College of Medicine in Houston and served as a chief fellow in his senior year in 2013 when he trained for nephrology. Then he moved to Detroit, Michigan to join the Wayne State University as a faculty and assistant professor of medicine. Dr. Imran has assumed several leadership positions since he started with Wayne State and served on many administrative roles. He served as associate program director for the nephrology fellowship before becoming the program director until 2020. He is currently the renal section chief at Karmanos Cancer Institute. In addition, he serves on multiple vital committees at the Department of Internal Medicine, including selective salary compensation, residency oversight, and the COVID-19 research steering committee. Dr. Imran is a School of Medicine College Teaching Award recipient in 2019 and the Mentor of the Year Award in the Internal Medicine Residency Program. In addition, he is the 2021 Paul Robel Teacher of the Year Award for Internal Medicine residents. He continued to be active and engaged with the teaching and medical students, residents, and fellows. He has mentored more than 50 medical students and more than 20 fellows in nephrology as well. He was the first author of 2 textbooks and multiple publications throughout the years, including the prestigious journal of CJASN. Dr. Imran is a fellow of several professional societies, including the American College of Physicians, American Society of Nephrology. In addition, he is a designated hypertension specialist by the American Society of Hypertension. With no further ado, Dr. Imran, please go ahead. Thanks for being with us, and please go ahead, share your screen for the presentation.
All right, thank you so much for the introduction and welcome everyone. I know it's 7 p.m. at night, so you're choosing to spend the time with us is very valuable, and hopefully you will walk away with more knowledge and hopefully some memorable lessons. So realizing that my audience is going to be diverse, I wanted this lecture to be as practical and as clinical as possible. And this is just to give you a glimpse of how most nephrologists, or at least myself, approach cases of congestive heart failure when we get consulted for fluid assessment or acute kidney injuries. So let's go. Okay. All right, so disclosures none. Learning objectives are recognize the interplay between the kidneys and the heart, assess the different biomarkers in CHF patients when it comes to volume assessment, review the various clinical cues and caveats, which includes, unfortunately, some red herring and some common mistakes clinicians make. But I wanted to start with few slides of background and definitions, so we all agree on what we're talking about. There is obviously a symbiotic relationship between the heart and the kidneys, and this was recognized for the past 200 years. And the common term that we are using these days is cardiorenal syndrome, and it was coined in 2004. Now, not every acute kidney injury is a cardiorenal syndrome, and not every cardiorenal necessarily an acute kidney injury. So we're going to go over that in a second. Cardiorenal syndrome is a broad spectrum or a broad scope of disorders of the heart and kidneys, whereby the dysfunction of one organ will negatively affect the other. Again, these are all basic definitions, not a lot of clinical practice there, and the different subtypes of cardiorenal syndromes include acute, chronic, cardiac, and renal disorders. And there are 5 types of cardiorenal syndromes. The type 1 is the acute cardiorenal syndrome, acute heart failure leading to an acute kidney injury. Type 2 is chronic heart failure leading to a chronic kidney disease. We're going to discuss mostly in these slides type 1 and type 2. And then you have the renocardiac syndrome, which is the other way around, where an acute kidney injury leading to an acute cardiac injury, CKD leading to a chronic heart failure or heart failure. This is in type 4, and a systematic disease causing both heart and kidney. And this is the graph of the creatinine that many nephrologists are familiar with when they're dealing with congestive heart failure. This is one of my patients that I took care of for the past 4+ years. Unfortunately, till she ended up on dialysis. Her dialysis was eventually due to sepsis, not for her heart failure. But what I wanted to show you here is that this is the natural progression of the disease when it comes to cardiorenal syndrome. You can see that initially there is some natural progression of the disease without much acute component. But later on, when the patient becomes sicker, and in this particular patient I'm going to discuss in the next slide, you can see the multiple AKIs, and every AKI make the baseline of creatinine and GFR higher and higher and higher, where she ends up unfortunately at a much worse place than when she started a year prior. And just a quick reminder of what's the expected annual decline in eGFR. It has been shown that the peak GFR is between 30, around 30 probably, and then after that, between age 30 and 50, depending on many baseline characteristics, there is an expected decline in GFR between 0.6 to 1 millimeter per minute per 1.73 meters squared per year. So if somebody, let's take the age 40, their GFR is 100. By the age of 80, then they will probably lose around 40, so that will put them at a GFR of 60, which is what you expect from a normal kidney function with no comorbidities. The problem is that from the GCHF trial, the chronic heart failure has shown how chronic heart failure patients in that trial have shown that they experience a much sharper slope of decline in their GFR. So the GFR is 3 times as much. So with the same example I gave earlier, the 40-year-old with a GFR of 100, let's assume that the patient got a myocarditis. We don't want to add hypertension or diabetes to the mix. Just severe myocarditis, viral, ended up with severe chronic heart failure. They expect to reach that GFR of 60 probably within 13 years, rather than 40 years, and they may end up on dialysis within 20 to 25 years before even they qualify for Social Security. So this is how important it is to take care of those heart failure patients for many reasons. One of them is to slow down the decline of their CKD. And if you take this and expand it, you can see that the multiple AKIs. Now, this is very intimidating to many clinicians when they see this swinging pattern. We sometimes call it sawtooth, pattern, where you see ups and down. But in nephrology, the differential diagnosis for that is very, very specific. It's actually 3 categories. One of those 3 categories is hemodynamics related to cardiac function. So it's a very easy diagnosis for us. But unfortunately, and the treatment is easy. The problem is if patients can't tolerate the therapy and they're compliant with that, because that's a lifelong treatment. So the question has always been, when we get with nephrologists get on board for those patients, to assess to diurese or not to diurese. And in order to answer that, we need to go over some definitions and obviously some pathophysiology processes. So what does really heart failure mean? I added those stars. I'm going to share the slides later on with everyone. The star on the right upper is for I feel that the most important slides in the presentation. And this is one of those slides. So what heart failure means is, very simply, it's a decrease in cardiac output and forward flow. And that can be because of many reasons. Obviously, the 2 obvious reasons are the diastolic or preserved ejection fraction heart failure, and the systolic or reduced ejection fraction. However, we tend to forget that cardiac ischemic events can also cause AKI regardless of the contrast. So even if, let's assume somebody did not receive the contrast for their cardiac ischemic event, for whatever reason, that can also cause cardiorenal syndrome. It's going to be an acute one. It's going to be type 1, the acute heart failure causing acute kidney injury. But that's one of the things that we forget. Another one, which is requires some imagination, because not every patient walking through the clinic has an AICD or on telemetry. You need to suspect arrhythmias, especially undiagnosed atrial fibrillation, especially the paroxysmal one, atrial flutter, certain heart blocks. When you see that pattern of cardiorenal syndrome that I showed you in the first slide, this is why I chose to show you in the first slide. If you see that pattern and you cannot find out what the reason is, and the patient fits the picture, they have some risk factors, and you ruled out systolic and diastolic heart failure, one of the things that you have to think of is paroxysmal atrial fibrillation. You will be surprised how many times you will diagnose that just by realizing that that pattern in creatinine. Pulmonary hypertension is another big thing. We unfortunately we live in a pandemic of obesity, and so many people today have obstructive sleep apnea and pulmonary, and that's a cause for pulmonary hypertension than ever before. Fewer people are smoking, but still COPD is still a very common disease. That's another cause for pulmonary hypertension. So the patient does not really must have a depressed ejection fraction or diastolic heart failure for the patient to get cardiorenal syndrome. Pulmonary hypertension from COPD, from obstructive sleep apnea, from any of those WHO classes of pulmonary hypertension can cause cardiorenal syndrome. Valvular heart diseases, which is the most common one, is probably the aortic stenosis one. That's the classic presentation. Pericardial disease to lesser extent, and myocardial disease, which can fall under 1 and 2. However, I must address the elephant in the room when it comes to cardiorenal syndrome that everybody forgets about, unfortunately, is hypertensive emergency. More often than not, hypertension gets treated as a separate disease than pulmonary edema. You treat the hypertension and you ask, I'll have a slide about that later on, but hypertensive emergency is a cause of cardiorenal syndrome. And again, I'm going to discuss the cardiorenal, not the renocardiac, which is type 3 and type 4. But in general, the exact pathophysiology of cardiorenal syndrome is unclear. There are some hypothesized mechanisms, such as increased central venous and abdominal pressure that will decrease the perfusion to the kidney. We'll go over that also. Reduced cardiac output and forward flow. The overactivation of renin-angiotensin-aldosterone system in a maladaptive way, and oxidative stress. And this is just a schematic overview of the type 1 and type 2, where you see the increased intra-abdominal hypertension, the central venous pressure, venous congestion, reducing perfusion. So the kidney gets hit by two things: the decreased hydrostatic pressure of the perfusion or from the cardiac output, and increased hydrostatic pressure from the venous congestion from the decreased venous return. The same thing goes for the chronic heart failure. So as I mentioned, it's basically arterial underfilling and venous congestion. And this will lead to, again, maladaptive renin release, upregulation of renin-angiotensin-aldosterone system, sympathetic nervous system activation, and neurohormonal activation that will lead to more sodium water retention, which will further worsen the heart failure, the arterial underfilling, venous congestion, and cycle repeat. And the same thing goes for the venous congestion. It's going to be, unfortunately, a vicious cycle. So the question of today's or not today's is basically how to evaluate for arterial underfilling and venous congestion. So therefore, we titrate up medications, or there might be something else, like we sometimes might diagnose somebody with overdiuresis, so you have to titrate down the medications, or maybe the medication itself that is causing the problem, not really the cardiorenal. So how can we titrate up or down the medications based on clinical assessments?
Dr. Imran, just one question. This question before we move on with the presentation. So when do you suggest that nephrology should be involved in such patient? Like, what is there a trigger where we have to keep in mind that nephrology has to be involved for creatinine or GFR?
So one thing I come to mind when, as cardiologist, you probably will expect a certain pattern when you start diuretics, blood pressure management, etc. When the patient does not fit that pattern, when you don't see the improvement you're expecting to see when it comes to volume or creatinine or urine output, I suggest to involve a nephrologist. But if the patient comes with a straightforward cardiorenal syndrome, you diurese, you address the patient medically, and they're getting better, you probably don't need to involve the nephrologist. But the earlier the better, I assume. But especially if the patient does not fit the pattern that you're expecting them to follow. All right. Yeah. And I encourage everyone, if they want to put their questions in the chat, because I'm going to cover a lot of material, so you don't forget your questions. So what's called guidelines directed medical therapy, there are many of them, but just to go over them quickly: diuretics, loop diuretics, and otherwise, the RAS inhibitors, the ACE, the ARBs, the anti-aldosterone meds, and the SGLT2 inhibitors. And it just so happens that all of them will interfere with renal physiology. So again, this is why we need to see if the rise in creatinine or the fall in the GFR is related to medication. Is it an accepted or expected change, or is it more than what we expect? And just another thing I wanted to cover before I go into the clinical part: cardiorenal syndrome is a pre-renal acute kidney injury. And not every pre-renal acute kidney injury you treat with fluid. We can all agree that cardiorenal syndrome should never receive IV fluid. So again, you will see some pre-renal pattern with cardiorenal syndrome. Do not give fluid, please. Again, the medical therapy that we mentioned in the last slides will influence the intraglomerular hydrostatic pressures in many ways. So, for example, the SGLT2 inhibitors and the loop diuretics, because they are natriuretic by definition, Obviously, SGL2 is glucouretic, but also it is natriuretic because it's inhibiting the sodium glucose by definition transporter. That will deliver more chloride to the macula densa. That's what we call the tubuloglomerular feedback, and that will cause afferent vasoconstriction, lowering the GFR, and that can raise the creatinine. And also the mitigation of efferent arterial vasoconstriction. Mitigation of vasoconstriction is just another way to say vasodilation. That also, that's the ACE and the ARB and the RNIs, will cause the glomerular pressure to go down, and basically the GFR to go down, and the creatinine will go up. So different mechanism for the creatinine rise, and from the three classes of medications. And though these changes, they will reduce the calculated GFR. All right, that does not necessarily mean they will cause injury. There's a difference. This is a calculated GFR. If you biopsy the kidneys, there will be no injury. These are just hemodynamic changes. So you should not stop the medications because the creatinine went up by 10% or 0.3 or 0.4. I have data to back that up. Again, we're going to come over that. And these will cause a prerenal AKI picture. Do not stop those medications, because you're better off, or your patient is actually better off being on these medications than stopping them, treating numbers, and forgetting about treating the patient. And again, to identify the cause of the AKI, it is very helpful to document as early as possible and as regular as possible in your notes, whether it is in inpatient settings or, more importantly, the outpatient settings, the trends of labs, the trends of vitals, including the weight, the medications, and the compliance. Because the one thing that nephrologists do probably more than anybody else, I assume, is they're looking at trends and historical data, because that's how we can deliver the right diagnosis. If you don't look at trends, you will never get the right diagnosis. And just for reference, I put the Framingham criteria for diagnosis of chronic heart failure. And you will see that when we go over those parameters, you want as many pieces of the puzzle to fit the full picture, or at least to give you the right picture. Not all pieces will fit the picture. You ignore those if the rest is directing you toward one diagnosis. Those patients are very complex. They have a lot of comorbidities. There are a lot of caveats. There are a lot of medications. So you have to be aware of them. And you need to look at the majority of the data points directing you toward one diagnosis, and you may need to ignore the rest conflicting data points.
Before you move on, Dr. Imran, we have a question. How important is the classification of cardiorenal syndrome 1 through 5, as you nicely described, and how does that affect the treatment?
So as we will see later on, the type 1 or the acute part, you have to increase the diuresis. You have to address the acute components eventually, and then you go back to the chronic type of treatment. So that's really the only difference. But most of the time it is it's just for research purposes.
Another question also related to something you covered already. Some nephrologists argue that renal venous congestion caused by heart failure is a more potent culprit in causing AKI and cardiorenal syndrome. There's a term for that called congestive nephropathy, or nephropathy. What's your thoughts?
I agree with that, especially if the patient is not hypertensive. So if the patient is hypertensive and the blood pressure is not controlled, or in certain scenarios, even hypertensive emergency, venous congestion is probably more important. But in certain other, again, this is an umbrella term that should not be hung on. Like, for example, the atrial fibrillation example I gave, if somebody, and you will see that in the ICU, if somebody is admitted to the hospital for a surgery and then all of a sudden they have an atrial fibrillation with rapid ventricular response, or they develop an acute MI post-surgery, or whatever, there is not enough venous congestion that built up to cause the congestive nephropathy. So that's mostly in the chronic phase. In those acute phases, it's mostly the forward flow. But again, I don't want to discuss semantics, because at the end of the day, you have to treat the etiology, and you have to decongest the patient, whether you're decongesting the lungs or you're decongesting the kidneys.
Perfect.
So what are those puzzle pieces that we want to discuss? All right. So as we're going to see, I'm going to discuss the trend of things that we can do bedside, trend of symptoms, weight, lower limb edema, blood pressure, heart rate, and lung exam. I'm going to discuss some blood tests, the BMP that everyone is familiar with, and uric acid and the brain natriuretic peptide, and some urine studies. And just an interesting an interesting article I found while preparing for this lecture is that this is an ER in an ER settings. Surveyed physicians were uncertain about the diagnosis in approximately 60% of cases when it comes to heart failure. This is a surveyed study. So the misdiagnosis rate, when they compared it to the gold standard based on totality of testing, including chest X-ray, BMP, and bedside assessment, was as high as 10 to 20%. So again, that's what I meant by you have to look at the different pieces of the puzzle and look at the majority where it's leading you, and then just follow what the majority of that is. But also, not to be discouraged, this is another article from the ESCAPE trial. They looked at clinical assessment alone in diagnosing and treating heart failure versus clinical assessment plus pulmonary artery catheter measurements. And they found that clinical assessment, a careful clinical assessment is as good as combined with the pulmonary artery catheter, which is like an invasive testing, as we all know, in treating and in prognostically for those patients. So if you do a careful assessment, you'll be as good as that invasive procedure. So let's go over the trend of symptoms and history. Let's go one by one. So obviously, orthopnea is one of the classic symptoms of congestive heart failure. It's very highly sensitive to diagnose a decompensated heart failure, and if the patient presents with orthopnea, a concomitant AKI is more likely than not due to acute cardiorenal syndrome rather than over diuresis. Again, remember, those patients will present in a pre-renal AKI pattern of lapse. Those patients need to be diuresed. Do not stop the diuretics. There is a term I'm probably going to start using for the rest of the lecture to borrow from our pulmocritical friends, permissive hypercreatinemia. It's okay to allow the creatinine to go up a little bit if what you're doing is the correct therapy and based on sound clinical judgment. It's okay to allow the creatinine to go up. So permissive hypercreatinemia, we should make that term more widely used. If your patient, again, trend of symptoms and history, if your patient experiences a lot of dietary indiscretions, medication non-compliance, uncontrolled hypertension, plus worsening lower limb edema, then a concomitant AKI is very likely also due to be a cardiorenal syndrome. Again, those patients will present in a pre-renal AKI picture, lab-wise and urine lab-wise. In those patients, you have to diurese. Do not stop the diuretics. Now, regarding the weight. So this is the European Heart Failure Self-Care Behavior Survey. They teach patients how to basically self-care when it comes to heart failure, because the cardiologist or the primary doctor is not won't be with the patients 24/7. So they try to educate their patients about how to self-care. And number one is they have to weigh themselves every day, different settings, etc. The only problem with that is that, again, this is when we're talking about, to go to the second question I had a couple of minutes ago, this is when you have chronic type 2 heart failure with worsening symptoms. And this is how pulmonary edema builds up in the lungs. There are different phases from the normal pulmonary capillary wedge pressure of 8 all the way up to phase 3, which is the alveolar edema. These stages can happen in a matter of hours, again, such as hypertensive emergency, an atrial fibrillation that was never diagnosed, a cardiac ischemic event, etc., or may happen in weeks. You're not always lucky to have it to happen over weeks. So you should not rely only on weight. An increasing weight in the right settings with symptoms and history, the AKI is likely due to an acute cardiorenal syndrome rather than over diurese, so diurese. However, a stable weight does not necessarily rule out a cardiorenal syndrome. And the example I gave is the type 1 cardiorenal syndrome, which is the acute part. In those patients, if you have if you have enough evidence that patient is congested and clinically they fit the picture, you have to continue diuresis. Now, if the weight is decreasing, that's the tricky part. There is a term called cardiac cachexia, which is the non-edematous weight loss of more than 6% within the prior 6 to 12 months, and it may affect as few as 10% up to more than 1/3 of patients. And usually those patients are in the advanced stage for heart failure. In those patients, you need definitely to commit, do not really necessarily commit to the diuresis. It's not an easy, as increasing weight or worsening symptoms. You have to look more into what exactly is the cause of the decreasing weight, because those patients may have other reasons for weight loss. One of them is cardiac cachexia, which is you have to obviously to diurese. You should not hold diuretics for those patients. Now, regarding lower limb edema, we can discuss a lot of things about lower limb edema. It's a sign of many pathologies. There's multiple articles and approaches, etc. But the one thing I wanted to focus on is, I mean, we all know the different medications that can cause lower limb edema, such as calcium channel blockers, such as amlodipine and nifedipine, and also just on the side, ACE are the best to address the vasogenic edema, not the thiazide. So you're better off combining the ACE with the calcium channel blocker rather than a thiazide with calcium channel blocker to address that edema. But having said that, the one thing I wanted to mention here is the pulmonary hypertension. So to go back to the example I gave earlier, the obstructive sleep apnea or COPD, those patients may have a completely normal left ventricle function, but they will have pulmonary hypertension and right heart failure with congestion. Their venous return is impaired. Their preload is impaired. They still have heart failure by definition because the heart is failing to do basically the perfusion. And in those patients, edema does not equal fluid overload. I cannot stress that enough. You have to see what the trend is. You have to carefully look into the cause of the edema, how their pulmonary hypertension is treated, if they're obstructive sleep apnea, COPD, etc., etc., etc. And one thing that is not mentioned here that you will find it maybe in a patient once or twice a year is a forgotten IVC filter planted that can cause bilateral lower limb edema. You will be surprised at how many times you will find that. All right. Now, what about the different blood pressure and heart rate? So again, it is why.
As we go, this question keep coming. Sorry to interrupt. What's the criteria for permissive creatinemia, that the one you mentioned earlier? Yeah. Is there a cutoff where creatinine level should prompt us to stop diuresis?
So I'm gonna. I will. If you can hold that question to the very end. I have a couple of slides for that.
Thank you.
All right. So again, it is widely accepted that hypotension and resting tachycardia are signs of severe and advanced heart failure. Okay. On the other hand, the management of hypertensive emergencies with flash pulmonary edema should focus more on controlling the blood pressure rather than diuresis. That's the elephant in the room that I mentioned earlier. Now, the reason for that, as a nephrologist, I see, at least myself, is a little, sometimes I get frustrated with this, is that, oh no, it's not this slide, it's going to be a different slide. The same goes for severe cardiac arrhythmias. Just because the blood pressure is low and the heart rate is high, if there is a cardiac arrhythmia to explain that, and that can cause the cardiac renal syndrome, address the cardiac arrhythmias there rather than focus on decongesting the patient. You may decongest the patient, but more focus should be on the primary etiology. And AKI in those clinical scenarios are by definition cardiorenal syndrome type 1, but diuresis, while can and probably should be started, should not be the mainstay of treatment for the AKI. So again, this is the scenario that we unfortunately we encounter more often than not, is that we get a call from ICU or from the emergency room, etc., or a request to arrange for an emergent dialysis treatment for a patient with pulmonary edema, severe AKI, sometimes ESRD, and uncontrolled hypertension. And as I mentioned earlier, if somebody is presenting with uncontrolled hypertension emergency, you should focus more on controlling the blood pressure, starting an antidrip or etc., starting their home medication, etc. Because the reason I'm saying that, because this emergent dialysis is not just a button I have to press. I wish that was the case. The best case scenario in those situations, if I am to start the dialysis for those patients for their AKI, is that I have myself, I have to assess the patient for 30 minutes. I have to call the dialysis nurse from home or they might be dialyzing someone else. So best case scenario, 45 minutes for them to get home. And we live in Detroit. Some of them will come from Canada, literally. Transferring the machine to the ER or the patient to the dialysis unit. This takes at least 15 minutes, not counting the elevators. Preparing and setting up the dialysis machine, that's another 30 minutes. 2 hours have passed before the first drop of ultrafiltration, and that does not even include the time if we have to put a dialysis line and then check the chest X-ray. So at least 2-3 hours will pass, and the patient is still huffing and puffing, and we forget that a better way to help with this patient is to control the blood pressure and focus more on that. Just because you call the nephrologist, magic doesn't always happen. All right. So what about lung exam? Because we all agree that Rales, S3, and congestion and chest X-ray equals CHF. And an AKI in these settings is most likely due to cardiorenal syndrome. That's the easy part. The problem is that Rales and wheezing may present during the acute decompensation, but in chronic heart failure or type 2 heart failure, because of the compensatory increase in lymphatic drainage, sometimes this might not be present. So the absence of Rales does not necessarily mean no heart failure. So in the right settings, you have to continue diuresis. Again, the most specific sign is elevated JVP and S3 gallop, but the specificity is great, but the sensitivity is not. And sometimes it's really hard to look for this elevated venous pressure, especially if the patient already got the central line, etc. So you can check the CVP through the central line, but we're talking about a bedside exam here. And also, up to 20% of patients with acute decompensated heart failure may lack the congestion in chest radiograph, and that has to do with the moment the X-ray was taken, whether it is during inhalation or inspiration or expiration. So especially those with end-stage heart failure, they might be congested, but just radiograph does not really show it. So in those cases, if RALs are not present, there is no S3 gallop, there is no congestion, you may not necessarily need to commit to diuresis, but in the right settings, if everything else fits, then you have to do diuresis. Again, as I mentioned earlier, you might have 8 out of 10, 18 out of 25 signs of heart failure. Not every sign will agree with you. So again, and the other thing I wanted to mention is the presence of pleural effusion. Even, and this is a study in patients with idiopathic pulmonary arterial hypertension with completely normal left ventricle. They have an isolated right heart failure and they still have pleural effusion. So pleural effusion does not always necessarily mean they are fluid overloaded from left heart failure. That can also happen in right heart failure. And in those patients, you have to be careful with diuresis because those patients are preload dependent, and an AKI in those patients might be exacerbated by diuretics. So you need to involve the pulmonologist and the treatment they're giving these days for pulmonary arterial hypertension rather than focusing on diuresis. So this, in those patients, at least, if you take 100 patients of these patients who are isolated pulmonary arterial hypertension, your odds are to stop diuresis is probably you're better off than continuing diuresis. And many of those patients, as I mentioned earlier, with pulmonary hypertension will have lower limb edema. That's not necessarily a sign of fluid overload in the entirety of the body. So again, you don't have to diurese. Now, so we discussed the bedside clinical assessment. So let's go over the BNP. So BNP, or the brain natriuretic peptide assays, have higher sensitivity compared with the N-terminal assays. I think we most of the time we use the NT1. It has more the higher specificity, and BNP assays that are very sensitive. Thus, they exclude heart failure if they're normal. But BNP, if it is positive, it has if it's positive, it has because of its specificity, it has a higher or better positive predictive value. And also BNP, as we know, it's also has a prognostic value. This is a study looking at not even a year post hospitalization, patients above or below the median of their BNP, and you can see that the hospitalization-free survival is almost twice as much, if not even more. And the problem with those assays is they're useful diagnostically, but there are some caveats remain. The famous caveat I think most trainees know is obesity is associated with lower BNP. Elderly and females are associated with higher BNP. Men are lower, obviously. And also, more importantly, that the level of BNP in non-cardiac conditions can also go up, such as advanced chronic kidney disease, acute pulmonary embolism, and pulmonary hypertension. So we have to know your patient. Again, just because the BNP is high does not necessarily mean a fluid overload, especially if there is a concomitant chronic kidney disease or an acute kidney injury on top of the CKD. So you have to, again, look at all the data points, not only one. And also, the thing is that is advantage and disadvantage at the same time. There is a substantial inter-assay and intra-individual variation in BNP levels. So it's mostly useful if you do serial measurements. So if your patient is feeling great, they are on the guideline directed medical therapy, vitals are controlled, everything. This is the time you want to check their BNP, and then for future reference, compare that to that level. Again, this is not the only data point that you will look at in the future, but it's definitely going to be a very useful one. At least in my VA clinic, those patients with CHF, because I'm dealing with a lot of elderly men, basically with a lot of comorbidities. Everybody with CHF, I get a BNP just so I can review that in the future. Now, what about uric acid? Uric acid is a little bit controversial, especially if we have a nephrologist on the call. From the hyponatremia and SIDH literature, it is a low uric acid and a high fraction excretion of uric acid. They go together. Low serum uric acid and high fraction excretion uric acid suggests a status of hypervolemia. However, hyperuricemia has been recognized as a strong independent predictor of morbidity and mortality in heart failure, which is the other way around. So studies have showed that uric acid predicts incident heart failure with both preserved and reduced ejection fraction. And one of the SGLT2 inhibitors, dapagliflozin, significantly reduced uric acid levels in patients with heart failure. So you cannot really borrow from the nephrology literature or regarding the uric acid when it comes to the heart failure literature. So I see some nephrologists will use uric acid as a marker for volume. You should not. You should not rely on that. And this is a study showing patients with normal uric acid versus high uric acid, and they're looking at different parameters when it comes to their heart failure. The high uric acid in this, it was a European study, so they used the millimole per liter. When you convert it to milligram per deciliter, the units we use, it's around 8. So it's generous. So it's on the higher side, 8 milligram per deciliter. They found that after multivariate analysis and looking at all the confounding factors, loop diuretics did not affect the level of uric acid. So that's also another myth I'm more than happy to debunk today. Loop diuretics does not necessarily increase high uric acid, at least in CHF literature. And patients with lower cardiac index and worse pulmonary capillary wedge pressure tend to have high uric acid. Again, it's as shown in other studies, it is a predictor of worse heart failure. And this is the same study looking at 9 years or almost 10 years out of the from enrollment. Those with higher uric acid were worse off in terms of survival and combined endpoint meaning mortality, heart transplant, LVAD, and heart or total heart artificial heart implantation. So the bottom line: do not use uric acid as a volume marker, especially if you're a nephrologist. This is one of the myths that we unfortunately got trained to do. Now, there are a couple of trials also showed no benefits in lowering uric acid and targeting that in CHF patients. So again, if the patient does not have gout or another reason to start allopurinol or the other medications, you don't have to. There's no evidence yet to suggest or to support using a medication that will lower uric acid. As I said earlier, several studies have shown that hyperuricemia remains a strong predictor. Of course, outcomes even after adjusting for loop diuretics and renal function. And yes, so this is exactly what this is just a reiteration of what I mentioned earlier. The uric acid should not direct diuresis, and if a CHF patient has an AKI. So do not stop diuresis. Now, what about the fractional excretion of uric acid? That's not the same. So the problem is with that is that many patients are on losartan, which is a uric agent, thus will alter the fractional excretion of uric acid. And this is just a simple case series of around 6 patients. They're trying to show proof of concept that the fractional excretion of uric acid can help or can add a piece of the puzzle to your bedside clinical assessment. In that study, they showed that patients who have conflicting data points and how they use the fractional excretion of uric acid, a high fractional excretion of uric acid indicate volume contraction over diuresis or low flow versus otherwise. I mean, I don't think it will be. I mean, you can use it. It's another arrow in your quiver, so you really don't need to use it all the time. But in the right settings, you can remember that you have this trick up your sleeve.
We have a question, Dr. Imran,
Yes.
about the value of urine tests, urine analysis. I'm not sure it's going to come up soon about.
Yeah, I'm coming to the rest of the urine.
Yeah, the other one is the value of bedside echo and evaluating the compressibility of the IVC to evaluate the filling pressures or the volume status of the patient to diagnose cardiorenal.
So it's a good question. What I wanted to focus more on this lecture is the things that most people will be able to have access to, such as bedside clinical assessment history physical, BMP, simple blood test, and simple urine test. I didn't go into the invasive testing. I mean, the bedside echo, not everyone has the access to that, not yet at least. I know more people that not have those handheld devices. The thing is that the same caveats include pulmonary hypertension, right heart failure, and stuff like that. And if somebody is, that sick, to have to be in ICU and inpatient settings, that I assume can also be used to direct the diuresis. But I would probably look at it the other way around, not the lack of compressibility, but the compressibility. So I will use it in a negative way. If the IVC is collapsed, more like I would use that as more valuable than if the IVC is not collapsed. because there's so many caveats that go into the other one. But a collapsed IVC is almost always hypovolemia. So this is, it will be more useful there, I believe.
Okay.
But I mean, we can debate.
Now regarding Imran, we have 10 minutes left. Let's just go ahead, please.
Okay. So regarding the fractional excretion of sodium and fractional excretion of urea. So cardiorenal syndrome, as I mentioned, is a prerenal state. So because of that, the low phenol, low urea will neither indicate over-diuresis or under-diuresis. And an AKI and CHF patients with those will not have any true diagnostic value. So they might have some prognostic value, and there is a trial that is looking at natriuresis guided therapy in acute heart failure by testing the urine sodium still under, they're recruiting, they're looking into that. So, so stay tuned. So in short, I advise against using phenol for urea and evaluating an AKI in CHF patients. Now regarding the sodium, since we have only 10 minutes left. So sodium abnormalities are common among CHF patients. In study of more than 100,000 CHF patients, hyponatremia was present in at least 1/5 of those. And all dysnatremias, hypo and hyper, regardless of how mild it was associated with worse renal outcomes. And hyponatremia itself can worsen neurohormonal activity, the very pathophysiology that we mentioned earlier in cardiorenal syndrome, and can also worsen the diuretic-induced AKI if it is due to over-diuresis. It has been shown that for more than 2 decades that, again, compared with normal natremic patients, hyponatremia have higher circulating level of neurohormones and decreased renal function. In those patients with hyponatremia, diuresis. What about hypernatremia? Because that's by definition is dehydration. Do we need to stop diuresis if you see hypernatremia? Well, the answer to that is it depends. Because most of those patients, if you just try to remember some of those that you've seen over the years with hypernatremia and CHF, more likely than not, they are elderly, and the hypernatremia might be a surrogate marker for limited physical and mental capacity, and those patients might actually not be very compliant with their medications at no fault of their own. So when you see those patients, if the only thing that is directing you to hold your diuresis is the hypernatremia, you can safely ignore that, and you can continue diuresis, but with caution, because again, most of the time, those patients might actually be they have other limitations or incapacitations. Now, regarding calcium and bicarb, and in order to understand the relationship between calcium and bicarb, I actually had a slide about how does calcium and the loop diuretics interact. This is the ascending loop of Henle. This is the where the furosemide or the loop diuretics work. It's the sodium potassium 2 chloride channel. Okay, yeah. So this is it gets absorbed through this channel. It doesn't get absorbed paracellularly because of the tight junctions that we're looking at, and because of the this reflects the serum sodium, potassium, and chloride levels. Potassium, which is the lowest, is the limiting step. So we have the other channel here. It's called renal automedullary potassium channel that leaks potassium and increasing the potassium in the luminal part of the ascending loop of Henle. So thus, that channel will make the other channel go its way. And then the sodium will eventually get reabsorbed from the other side, and through the sodium ATP is pumped, and that potassium will continue to feed the other channel. And of course, chloride will be also involved. Why I'm mentioning all of that when we're talking about calcium? Because that extra potassium that is being secreted on the left upper side will cause the luminal to be more electropositive, and that will cause the calcium and magnesium to paracellularly being absorbed. And when enough calcium is being absorbed, the calcium sensing receptor will, by definition, since the receptor that senses calcium, will inhibit the rump channel and put it into a halt. And this is why hypercalcemia indirectly inhibits the sodium potassium chloride channel. Or in other words, hypercalcemia will cause the same effect as loop diuretics, an overdose of loop diuretics. But the other way around also, too much loop diuretics will cause hypercalcemia for the same reason that we're going to see in this slide, which is when more calcium is being not absorbed at the ascending lobe of Henle and they reach the distal convoluted tubule, that extra calcium will activate the calcium sensing receptor in the DCTs, and that will increase the calcium absorption. And because of the sodium calcium exchanger on the other side, you will end up more natriuresis and more calcium absorption. And the calcium itself on the collecting duct will decrease the cyclic AMP intracellularly, and that will decrease the aquaporin and diuresis. So in essence, hypercalcemia acts as loop diuretics, and loop diuretics by itself, because of the effect downstream, will cause hypercalcemia. So what am I saying this for? This hypercalcemia is probably about the best test you can have for volume depletion, rapid diuresis, or over diuresis. So I know that I told you about the different pieces of the puzzle. This one probably has more weight than others, the calcium and also the bicarb. However, there are caveats. The problem is that many of those patients will be on thiazide. Thiazide can cause hypercalcemia. Many of those patients might be on having a hypervitaminosis D, especially if the elderly on osteoporotic, etc. And there are other causes of hypercalcemia. And also, again, if somebody has a severe COPD or obstructive sleep apnea, you cannot rely on the bicarb or the metabolic alkalosis to label the patient as over-diuresed or volume depleted, etc. So again, AKI is mostly due to volume depletion, not cardiorenal syndrome in those patients. You can hold diuresis, but I would like to have more evidence for that, not just rely on one data point. Other than that, to answer the question that was mentioned earlier, when it comes to how much we accept hypercreatinemia, in the consensus trial, they found that ACE inhibitors that substantially increased creatinine more than 30%, those patients, the ACE inhibitor was as effective as those who did not have an increased creatinine. Again, this is not an acute kidney injury. The creatinine does not go up because of acute kidney injury. This is just hemodynamic. And once you stop the ACE inhibitors, they will go down. You should never do that. You should continue the ACE inhibitors, especially if the creatinine goes up and continues stable after that. And the other medications that I really want to highlight is the AGL2 inhibitors. There's a term we use now these days is dippers. GFR, it's not a drop, sorry, it's a drip. It's a GFR dippers, not drop. So almost 1/3 of those patients will dip, other will dip more than others, and it's more than 1 to 10 and no GFR. And if you look at those dippers, more than 10% GFR drop, if you stop the empagliflozin in this case, 4 weeks after that, they will all go back to their baseline. So again, it's not an injury, it's just a hemodynamic. So there is a conflicting data about whether a rising creatinine indicates good or poor prognosis in terms of acute heart failure management in patients. But we all agree that, and the same thing goes for BUN, but a good diuretic response indicates a less severe CHF status, even if the creatinine rises. So to go back to questions, the first question by Shadi is that if the patient is responding well and they're decongested, the symptoms are better, ignore the creatinine. Otherwise, we can involve a nephrosis because the patient might have other causes of AKI, not only cardiorenal. And in the ESCAPE trial, I just want to mention that the right atrial pressure correlated well with their baseline renal function and thus predicted mortality in heart failure hospitalizations. This is the last slide that also I wanted everyone to be aware of. There is no differences between furosemide and torsemide. You can use either. The only thing you just need to know is the furosemide has a variable bioavailability, so give and monitor. There are no enough differences between IV pushes versus infusion. I'm aware of the dose trial, but you have to know your facility. So if your nurse is taking care of 4 different patients, the IV line is out, the IV drip has to be replaced, we forgot to bolus before the IV infusion. There's so many problems that can happen with the infusion. I prefer giving IV push every Q6 and call it the day. And regarding combination diuretic loop and thiazide, starting off the bat with those combination, if the patient is not if that's not their home regimen, put them at a high risk for AKI and hypokalemia. So you can wait till you show no response and then you add it. Unless that's part of their home medication, then you can just go ahead and start it. And loop diuretics will work less efficiently in the following scenarios: advanced CKD, significant hypoalbuminemia because that increases the volume of distribution, significant proteinuria because furosemide is protein bound by 90%, and if there is no salt restrictions. I'm not sure if we have more time, but I have only one slide, but this is just the breaking phenomena I wanted to mention, that you cannot have a good diuretic response if you're not limiting dietary sodium intake. And that's the last slide. The take-home points are AKI in CHF patients is not always a cardiorenal syndrome. Do not rely only on one clinical parameters to assign an etiology to the AKI. The use of diuretics comes with many caveats, and most importantly, have a high threshold to discontinue the guidelines-directed medical therapy when the GFR declines, because you're more likely than not to cause harm to the patients than benefit. You don't want to treat numbers. You want to treat the patient. And thank you.
Thank you so much, Dr. Imran. I know we are over time, but if you have 1 minute to comment.
I have a lot.
Yeah, if you have just to comment to the audience about kidney injury in patient on ECMO, how to prevent it and what is the mechanism. I know it's too short, 1 minute to talk about this big topic, but something just to cover last minute.
I mean, so for ECMO in particular is that one thing that there are obviously on heparin, the hemolysis that can, the pigment nephropathy that can happen. That's the one thing I can think of. But of course, as you know, as other patients, they can have the pre-renal turning into ATN. Most of those patients in ECMO, unless you're starting it on a young, healthy individual with severe COVID pneumonia, many of those patients, you will see that they have bilateral renal artery stenosis and atherosclerosis. So they have their autoregulation and the tubular feedback is very impaired. So any differences in the like hypotension, tachycardia, or even bradycardia or hypertension, that autoregulation is completely impaired in those patients with diabetes and hypertension. That by itself can cause a pre-renal AKI and also ATN. But I will add a pigment nephropathy to the mix.
Fantastic lecture. You covered a lot of territory. I just wanted, just as a general look, when you're consulted on a postoperative patient with a rising creatinine, what is the usual thing that you encounter? Do you think it's primarily hypovolemia and pre-renal, or do you see it as being nephrotoxicity? You see it as being overdiuresis? What's your usual pattern of consult?
Most of the time, I act more royal than the king, and I advise diuresis. So especially that if there is a cardiology on board, they will ask us to volume assessment and diuretic response. And most of the time, actually, I feel the patients are under diuresed, and the GDMT or the guideline directed medical therapy has been prematurely stopped. So I will actually advise for more medications, but that's at least my experience.
There's one more question about chloride depletion alkalosis from diuretics. Does it need to be confirmed? Is it dangerous? When do you check pH?
So this is a very good question. So I think part of it is because the chloride level is at the macula densa. It's the macula densa is chloride run. To be honest, Dr. Warkana is my attending from my fellowship. So I have to circulate back to you, Dr. Warkana, about the answer for that. So I don't want to give you a wrong answer.
We have few requests about having the slide, Dr. Imran, if that's possible.
I'm sorry?
We have few requests. People text me on the side. They requested your slides.
Sure, absolutely.
Okay. So just, I mean, thank you again.
Chadi, this lecture is going to be posted on the website.
Yes. Yeah.
So they'll be able to watch it as many times as they want.
Correct. So yeah, I mean, I was about just to show that these lectures are all hosted on the YouTube channel for the DMC Medical Group. We're going to share the link also. Just if you can, this is going to be live maybe in 7 to 10 days after editing. But we'll share the link as well in the future webinars. And also, since you registered to the webinar, we'll email it to the group as well. You're welcome. Thank you again, Dr. Imran, for your time. And please, for all the audience, if you have any question related to cardiovascular, these are the numbers. And these are the webinars that have been hosted. This is our, believe it or not, this is our 20th webinar. We started during COVID and we're still going. This is once a month, come to you every last Thursday of the month. Next month, we're going to be talking about a weight loss surgery and impact of that on cardiovascular risk as well as benefits. I would like to thank my co-host, Dr. Kenton Zaire, for really supporting and initiating this program from the beginning. Sherry Alvarado for the hard work with Kenneth Baylor about all the technical and getting the CME for this program. Thank you for the audience. Thanks for staying late. Phenomenal talk, very educational, very rich. It's hard to digest. We need some Lasix just to kind of ingest.
You're having the bariatric surgery lecture next month.
Yes, yeah. Thank you, Dr.
Or torsemide.
Torsemide, yes, very absorbed. Thank you all for your time. And please don't forget to fill the survey that's going to receive in an email. And then you will get your certificate within a week from Sherry Alvarado. Thank you so much for joining us. Enjoying your evening.